Hi, my name is Kaitlin Sheets, and this is my presentation on celiac disease. Celiac disease is a lower gastrointestinal tract disorder or malabsorption syndrome and autoimmune disease affecting genetically predisposed people. The disease causes damage to the villi of the small intestine, the main location of nutrient absorption upon consumption of gluten. Gluten is a constituent of certain grains, including wheat, barley, and rye. It is estimated that 1 in 100 people worldwide have celiac disease. As a result of a meta-analysis conducted in 2016, it was found that the current worldwide prevalence of celiac disease is 1.4% based on blood tests and 0.7% based on biopsy results. As a result, it was determined that the prevalence of celiac disease was 0.4% in South America, 0.5% in Africa and North America, 0.6% in Asia, and 0.8% in Europe and Oceania. The prevalence was higher in female than male individuals and was significantly greater in children than adults. From these findings, it can be determined that the prevalence of celiac disease varies with sex, age, and location. In the United States, there are currently 2.5 million Americans with celiac disease who are currently undiagnosed and at risk for long-term complications associated with the disease. Celiac disease is a hereditary disease. Individuals with a parent, child, or sibling with celiac disease have a 1 in 10 risk of developing the disease as well. Celiac disease is caused by a deficit in the intestinal enzyme tissue transglutaminase, also known as TTG, that prevents further digestion and breakdown of gliadin and glutenin, the building blocks of gluten. When an individual with celiac disease consumes gluten, it causes a digestive blockage in the intestine as well as an immune response that attacks the small intestine. The combination of a digestive block and an immunologic response in the person results in a toxic effect on the individual's villi. The villi then atrophy, resulting in decreased enzyme production and less surface area available for absorption of nutrients, leading to malabsorption. A combination of the individual's genes, diet, and other risk factors may predispose them to celiac disease. However, the precise cause in some cases is unknown. It is thought that infant feeding practices, gastrointestinal infections, and gut bacteria might contribute as well. In some cases, an individual's celiac disease becomes active after surgery, pregnancy, childbirth, viral infection, or severe emotional stress. Symptoms associated with celiac disease differ greatly depending on the age of development, whether the individual is an adult or a child. Common digestive signs and symptoms associated with celiac disease in adults include stonorrhea, muscle wasting, failure to gain weight, irritability, and malaise. Intestinal damage often leads to diarrhea, fatigue, weight loss, bloating, and anemia, and can lead to other serious complications. In addition to digestive symptoms, some individuals may experience some seemingly unrelated symptoms such as anemia, loss of bone density or softening of bone, itching and blistering skin rash, mouth ulcers, nervous system injury such as numbness and tingling in the feet and hands, possible problems with balance, and cognitive impairment, as well as joint pain and reduced function of the spleen. Children with celiac disease are more likely to have digestive problems such as nausea, vomiting, chronic diarrhea, a swollen belly, constipation, gas, as well as pale and foul-smelling stools. The inability for the child to absorb nutrients as a result of celiac disease may lead to failure to thrive in infants, damaged tooth enamel, weight loss, anemia, irritability, short stature, delayed puberty, as well as neurological symptoms such as ADHD, learning disabilities, headaches, lack of muscle coordination, and seizures. Diagnostic testing for celiac disease typically begins with 2 simple blood tests, a serology test and a genetic test. A serology test examines the antibodies within the individual's blood for elevated levels of tissue transglutaminase IgA antibody plus an IgA antibody in order to ensure that the patient generates enough of this antibody to render the celiac disease test accurate, indicating an immune reaction to gluten. The TTG IgA test is considered to be 98% accurate. The TTG test is the most sensitive test for celiac disease. However, it is important to mention that there is a small risk of a false positive test result, specifically in individuals with associated autoimmune disorders such as type 1 diabetes, autoimmune liver disease, Hashimoto's thyroiditis, psoriatic or rheumatoid arthritis, and heart failure who do not have celiac disease. Genetic testing for celiac disease tests for human leukocyte antigens HLA-DQ2 and HLA-DQ8. If the HLA genes are not present, celiac disease can be ruled out. However, a positive genetic test for HLA-DQ2 and HLA-DQ8 genes should be followed up with a celiac disease blood panel to determine if you have celiac disease. If the results of the blood panel indicate celiac disease, the individual's doctor will likely recommend an endoscopy or a capsule endoscopy. An endoscopy is a test where a long tube with a camera is passed down the throat and allows the doctor to view the small intestine and take small tissue samples to analyze for villi damage. The alternative method is a video capsule endoscopy, or VCE. This test uses a wireless camera inside of a capsule, which is swallowed to capture photographs of the individual's small intestine. The video captures thousands of pictures that are transmitted to a recorder for analyzation. An IFABP, or intestinal fatty acid binding protein test, can be conducted. IFABP is a systolic protein released when cellular damage occurs in the systemic blood circuit and can indicate unintentional gluten intake. Radiology may be used to find any indication of the presence of celiac disease, such as small bowel dilation, wall thickening, vascular changes, or other indicators. The only way to confirm a celiac disease diagnosis is to do a duodenal autopsy. In a duodenal autopsy, 4 to 6 samples of the lining of the small intestine are studied under a microscope to look for damage and inflammation due to celiac disease. The gluten challenge may be recommended by a physician trained in celiac disease if the individual is currently on a gluten-free diet in order to allow antibodies to build in the bloodstream prior to testing for 6 to 8 weeks. Removing gluten from the individual's diet will gradually reduce inflammation in the small intestine, causing them to feel better and eventually heal. Commonly, children tend to heal more quickly than adults. If the individual's anemia or nutritional deficiencies are severe, vitamin and mineral supplements may be recommended, such as copper, folate, iron, vitamin B12, vitamin D, and vitamin K, as well as zinc. If intestinal inflammation is severe, steroids may be prescribed to control inflammation. Malabsorption and malnutrition occur when the small intestine can't absorb enough nutrients and can lead to anemia and weight loss. In children, malnutrition can cause slow growth and short stature. Malabsorption of calcium and vitamin D can lead to a softening of the bone in children and loss of bone density in adults, as well as can contribute to reproductive issues in women with celiac disease. Damage to the small intestine may cause abdominal pain and diarrhea after eating or drinking lactose. It is possible after the individual's intestine has healed, they may regain tolerance to lactose again. People with celiac disease who don't maintain a gluten-free diet have a 2 times greater risk of developing coronary artery disease and a 4 times greater risk of developing small bowel cancers. Some people with celiac disease can develop problems such as seizure or disease of the nerves to the hands and feet. Untreated celiac disease can lead to the development of other autoimmune disorders such as type 1 diabetes and multiple sclerosis. If you take a look at the table, you can see that the age of diagnosis is directly correlated to the likelihood of an individual developing another autoimmune disease. Complications associated with undiagnosed celiac disease include iron deficiency, anemia, early onset osteoporosis, infertility and miscarriage, lactose intolerance, vitamin and mineral deficiencies, central and peripheral nervous system disorders, pancreatic insufficiency, intestinal lymphomas and other GI cancers, gallbladder malfunction, as well as neurological manifestations including ataxia, epileptic seizures, dementia, migraine, neuropathy, myopathy, and multifocal leukoencephalopathy. The long-term prognosis for individuals with untreated celiac disease can vary depending on the individual's symptoms and malabsorption features. Overall, people with untreated or unresponsive celiac disease have an increased early mortality compared to the general population. And without diagnosis and treatment, celiac disease is ultimately fatal in 10 to 30% of people. The long-term prognosis for individuals with treated celiac disease is good. Following a gluten-free diet typically heals the damage to the intestine and prevents further damage. In children, healing is common within 3 to 6 months, and in adults, healing is common within 2 to 3 years. In rare cases, there can be long-term damage to the lining of the intestine before the diagnosis is made. However, strictly adhering to a gluten-free diet also significantly decreases the individual's risk of cancer. Currently, there is no preventative methods of developing celiac disease. There are only methods to manage the conditions, as mentioned, by adhering to a gluten-free diet. Follow-ups should assess symptoms, perform a complete physical exam, order celiac serology tests examining the anti-DGP IgA and anti-TTG IgA levels, repeat routine tests, order any other tests as clinically indicated. Individuals are also recommended a flu shot, seeing a dietitian to provide education and counseling, and seeing a mental professional to assess psychosocial aspects of going gluten-free and coping with a chronic disease as needed. Bone densitometry tests should be repeated at 2 to 3 years if previously abnormal and for adolescents non-compliant with a gluten-free diet. Adults should consider repeat small intestinal biopsy at 3 to 5 years to assess dietary compliance and rule out refractory celiac disease. And here you can see my sources. Thanks so much for listening.